Hello and welcome to a new section of OT 506 Pharmacology. We're moving into drugs that affect various aspects of the cardiovascular system. Certainly includes the heart, the blood vessels, and the autonomic systems that regulate those two systems. Chapter 7 will deal specifically with atherosclerosis, which is the hardening and occlusion of all blood vessels, not just coronary arteries. Coronary arteries certainly are a major factor because the heart is one of those organs that I say doesn't have a sense of humor. It can't function well or long with a diminishment in blood flow, so it's particularly acute. But certainly the brain, certainly the kidneys are also in that realm. Muscles, can go for quite a while without full blood flow, though there are manifestations, and we may talk about that a little bit. Thrombosis is the actual forming of an acute occlusion in a blood vessel or vein. We often will talk about deep vein thrombosis. And if that thrombus breaks off and moves to another part of the body, we call that an embolism. So we're going to get through some of the pathogenesis of coronary occlusion, and we'll talk about angina, chest pain, and we will then move into the drug therapies that are used to treat these things. Just a few terms here. We have arteriosclerosis, which most of us are probably familiar with. This is the hardening, loss of elasticity of medium or large arteries. Two things. One is you have loss of compliance, that is the ability to stretch and absorb that systolic pressure wave. Loss of elastance, that is to return to its original state. That compliance and elastance actually allows for much smoother blood flow and less high, and not higher highs and lower lows. When you have hardening, the systolic tends to go higher, the diastolic tends to go lower, and the blood flow tends to be more spurty. And that's actually not good. We want a nice smooth laminar flow. And compliance and elastance are key elements of the vascular system to maintain that smooth laminar flow. And if you have loss of that, coupled with occlusion, that causes a disrupted flow, and that's much more likely to trigger clotting and injury on the endothelial cells lining the arteries. We have arteriolosclerosis. This is smaller vessels. This is generally arteries less than 1/8 of an inch, probably more like 1/16 of an inch or less. Arterioles, meta-arterioles. These guys really do need to be elastic, and they are also vulnerable to occlusion. Atherosclerosis covers both of the arterio and arteriolosclerosis. It's hardening of any artery. Again, loss of compliance, loss of elastance, oftentimes due to what we call plaques. So hardening is the occlusion, and oftentimes the buildup of a plaque alongside it, which is made up of calcium and cellular debris. Anything that's atherogenic, like for instance LDL, low density lipoprotein, cholesterol, and so forth, substances or processes. It's not just bad things flowing in the blood. It can be due to things like anatomical features. We know fairly precisely where plaques tend to want to build up in the coronary architecture. So it's not, and it's back to the idea of smooth flow. If you have a hard turn, a hard change in direction, that change in direction, there's going to be some turbulence, and that turbulence can then lead to development of hardening and plaque deposition. And that process of building a plaque is called atherogenesis. So here's some terms for you. Just again, to help you integrate the medical terminology with the physiology and the drug therapy. The fundamental aspect of hardening of arteries is that it contributes to what we call a supply-demand mismatch. That is, the heart needs more oxygen than the supply allows. We talk about MVO2, which is oxygen consumption, myocardial oxygen consumption. The V stands for sort of velocity, if you will. If you have increased heart rate, if you have to beat harder, and the walls of the heart are less compliant, that can be due to enlargement of the heart tissue. It can also, if you can also think indirectly in terms of the wall tension in large vessels that are not absorbing the energy well, that contributes to afterload. And so those three things mean the heart is working harder and needs more oxygen. Well, if you have obstruction, whether it's at the micro or the coronary, you're going to have diminished supply in the face of increased demand. Is there low pressure for some reason? Maybe there's an obstruction upstream, and that obstruction upstream is causing resistance, and so downstream of that obstruction, you have less pressure. Maybe there's less oxygen to begin with. Maybe you have some pulmonary disease like fibrosis or emphysema or something. You're a smoker, so you have less overall oxygen. Or anemia can also drive this as well, where there's not enough carrying capacity, and so you have what's called a supply-demand mismatch. Back to the idea of occlusion. The law that governs how much blood flow will occur is known as Poiseuille's law. Poiseuille's law looks kind of complicated, but you can break it down into basically three major elements. There's a coefficient there that's not all that important, but we have 1, 2, 3 factors. There's pi in there. We don't have to worry about pi all that much. These things on the left of this division sign are direct correlations. L stands for length. So if you double the length, you double the resistance. So it's a proportional, so resistance in the vessel increases as length increases. I like to use a sort of analogy that if I had a garden hose out in front of my yard that's 50 feet long, you turn on the faucet and you're going to get nice flow of water. If I took that hose and made it 50 miles long, that length would increase the resistance so much that even pressure out of a faucet would not be enough to carry that water 50 miles. Then you have this goofy looking one here. That's actually the Greek letter eta. That's viscosity. And viscosity really is not all too terribly important on a moment to moment. But if you have somebody who is dehydrated and already susceptible to vascular disease or already has profound vascular disease, it could be a factor. Viscosity, the thickness of the blood. And then again, it's a direct proportion. As you increase viscosity, you increase resistance. Where you really see viscosity play a role is in folks who are blood doping. Either they're re-injecting whole red blood cells into their bloodstream for athletic performance, or they're taking drugs, in particular one called EPO, which is erythropoietin. That's actually a hormone made by the kidney to increase red blood cell production, and cancer patients use that a lot. If somebody's on EPO, then viscosity might be a factor, particularly if, again, they're dehydrated and they're already resistant by virtue of having some disease present. So viscosity, again, a direct proportion. You increase viscosity, you increase resistance. But the big one, the really, really big one, is radius. That is radius of the given vessel. Okay. To be super technical, we're talking about the entire cross-sectional profile of a given set of vessels, but that's not important for us here. What happens is it's related to it's to the fourth power. So if we diminish radius, that knock-on effect of that diminishment is an exponent of 4. All right. So as we decrease radius, we can increase resistance, or vice versa. If we increase radius, we decrease resistance. And it's to the fourth power, so small moves can make big changes. And let's look at the numbers. All right, it's dramatic. All right, let's look at the next slide. Here we have a constant pressure, a system where we have pressure that is equal to both of these tubes. They're both low at the same level in that column. This one has a radius of, say, 1 centimeter, and this one has a radius of 2 centimeters. If you were to measure the flow, assuming that all things otherwise are equal, same length, et cetera, same viscosity, obviously, we would see a volume of 1 over here, all other things being equal. But with that radius of 2, you would see a volume of 16, and you can break this out. You can do all the math and so forth. But it's to the fourth power, so 2 times 2 times 2 times 2. So 2 times 2 is 4. Multiply it again by 2, that's 8. And then multiply it again by 2, you get 16. So if you double the radius, you have 1/16 of the resistance, which means 16 times the flow. If you cut radius in half, you would have 1/16 of the flow, a 90+% reduction. And with atherosclerotic plaques, what you get is a chronic progression of diminishment of the vessel diameter. Never mind if this thing breaks off and forms an embolus somewhere else. I really like this chart down here on the right. I think you don't have to memorize the numbers or anything along that line, but what it's showing us is the relationship of what it would take in order to sustain. So, for instance, let's say we have 120 millimeters of mercury, standard systolic flow. If we have a given radius, we would see 100 cubic centimeters a minute. All right. If we have just 20% occlusion, so just 1/5 of the diameter, that rate is cut in half, or more than half. It's cut by 60%. So that same flow, assuming 120 millimeters of mercury, only creates 41, and that's just 1/5. It would take a systolic pressure of almost 300 to restore normal blood flow in that one. 50%? We only have we lose roughly 95% of flow just by cutting that vasculature in half. 95% loss of blood flow, and we would have to have close to 2,000 millimeters of mercury in order to reestablish normal flow rate there. We get to 80%, you can see less than 0.2 cubic centimeters, it would take 75,000 millimeters of mercury pressure to restore. And we see beyond 80%. We see sometimes 95%, which means essentially zero blood flow. So again, as this occlusion occurs, and it occurs so slowly, it's one of those things, it's like trying to watch your hair grow. You can only notice it after there's significant change. And that's the trouble with the chronic disorder of arterio and atherosclerosis. So back to the idea of supply-demand mismatch. If we have a lot of demand due to rate, how hard it's beating, and how much force it takes to change the wall of the heart, the wall thickness is a big thing. All right, wall compliance. Certainly preload and afterload. That's demand, and if demand exceeds supply, again, how much blood flow? If we have occlusion, maybe the vessel in and of itself, that could be an unoccluded vessel that's too small. If we have an anatomical situation that's inappropriate, or it's due to atherosclerosis. If you have a fast enough heart, for instance, if the heart is trying to compensate, the thing that the heart that often happens is that if you have a mismatch, you get a sympathetic activation, a sympathetic reflex, which will cause the heart to beat faster. If the heart beats fast enough, what we see is we begin to see less available or less ability to fill because there's less time in between beats. Most of our heart fills during diastole, what we call late diastole, when the atria and the ventricles are both relaxed. Roughly 92 to 95% of filling occurs during the time that the ventricle and the atria are relaxed at late diastole. So if you start increasing rate to a point, now you're going to have less time for filling. Certainly pressure, again, that is due either to hardening and or occlusion. Behind the occlusion, you're going to have less perfusion pressure. And again, ventricular wall tension. As the heart beats harder and faster with chronic sympathetic stimulation, it enlarges. Left ventricular hypertrophy is very much a thing and can lead to all sorts of sequelae. That can be loss of perfusion, more difficulty beating, et cetera, et cetera. What causes atherosclerosis and by extension arterio and arteriolosclerosis? The most prevalent hypothesis for why we get this sort of damage, and it's so common that it's almost like, well, we don't even have to understand why. But if we don't get at the why, we don't get at the therapies which can effectively treat the why. We end up just treating symptoms rather than cause. For instance, nitrates are wonderful vasodilators, but what you're actually doing is you're treating symptoms for a problem that's already present. So we always are trying to understand what drives the etiology, even if that sometimes doesn't always feel as directly applicable, especially in our case when we're sort of downstream. The people come with the problems. Why should we worry about cause? We should always worry about cause, because maybe, just maybe, you might spot something that might make a real difference. The prevalent hypothesis is that you get what we call endothelial damage. It's the damage model. That is to say, the endothelium, the cells that line the inside of the arteries and the inner wall of the heart, start to undergo dysfunction. Whether that's, generally we believe that's due to injury. That could be due because of high blood pressure. You're getting a high energy systolic wave. High cholesterol, in particular LDL. We'll talk a little bit about HDLs and LDLs. I'm not going to go into the weeds too much there. Not all cholesterol is the same, and low density lipoproteins tend to be more damaging than high density ones. If you're a smoker, nicotine can contribute, and probably a whole bunch of other things. Okay. So even if you're vaping, which you're not inhaling, burning vegetable matter, which is just loaded with all kinds of crap. Even nicotine in and of itself, never mind some of the additives that go along in those vaping products. Or we could even talk about burning vegetable matter in other forms like marijuana, et cetera, cloves. Anytime you're inhaling smoke, you're getting irritants that could potentially lead to endothelial dysfunction. Diabetes, where we think diabetes is that the blood sugar, also triglycerides, we call it a metabolic syndrome. We're really talking about primarily type 2, but uncontrolled type 1 can also lead to issues as well. That high glucose, high fat, high triglyceride kind of a syndrome can lead to endothelial dysfunction, which then leads to athero and arteriosclerosis. So one of the families of drugs we're going to be talking about includes the nitrates. And so I just included the mechanism up here. Here's an endothelial cell. And this is why endothelial dysfunction is so important, because the endothelial cells are the source, primarily of nitric oxide. They have an enzyme called nitric oxide synthase. And they release that nitric oxide, and that nitric oxide will diffuse onto the smooth muscle that's outside of the endothelium in arteries. Arteries have layers of smooth, vascular smooth muscle. That nitric oxide contributes to a relaxation response. So let's bring this around. If we have endothelial dysfunction, even if it is an overt injury due to diet, maybe family history, irritants, poorly controlled sugar and triglycerides, high blood pressure, all sorts of things. All of these things contribute to loss of nitric oxide signaling by the endothelial cell, which means less relaxation, which means more spikes in blood pressure, means less laminar blood flow, and more likeliness to lead to what we call sequelae, the consequences of a dysfunctional process. So we have that cartoon on the previous slide. Let's sort of formalize that a little bit. So we have endothelial dysfunction right here. Well, what causes it? Well, it could be due to poorly controlled blood sugar, maybe coupled with high insulin. If you have insulin resistance, early type 2 syndrome, high fats, either LDLs, free fatty acids, cholesterol, etc. There are some other things out there, but all of these things contribute to what we call oxidative stress. And that oxidative stress means that the endothelium doesn't secrete as much nitric oxide and other things which regulate constriction dilation of vessels. And so what we get is a stiffness response. You can get an inflammation if it's overt injury. The blood is more likely to coagulate and so forth. And again, you have loss of ability to dilate, and that then leads to all of the things like here, for instance, again, more hardening. Overall pressure rises due to that hardening. The heart trying to work harder and leading to a hypertrophic heart that can't dilate properly and generate cardiac output, leading to MVO2 and mismatch issues. A little bit about how plaques build up. What we know is that you get endothelial dysfunction, and that can lead to increased, increased accumulation, if you will, due to the inflammatory process. It's chronic inflammation that often drives the buildup of plaque in a given location in an artery. And we talked about LDL versus HDL. What happens is LDL seems to be metabolized under an inflammatory profile. That inflammatory profile, you get accumulation of LDLs, but you also get infiltration of white blood cells. Because of that inflammation, these endothelial cells are secreting factors that attract the white blood cells. The white blood cells get activated, they get sticky. And so that's why they would accumulate in an area of inflammation. And they release their cytokines and they will absorb this LDL. But there's a point where they absorb so much LDL that they don't even look like white blood cells anymore. We start calling them foam cells because they are so full of lipoprotein that they just don't look like cells anymore. Again, LDL seems to be more causal than HDL. It's not entirely a bad thing. If you've got a boatload of HDL, you're going to have issues. The ratio here tends to be more important. You want to have the appropriate ratio. Yes, a lot of LDL, you're going to screw up the ratio, which means deposition. And LDL is much more pro-atherogenic than HDL is. So what we want is a balance. We want to be able to have the appropriate ratio. Most times what we have is an excess of LDL, and so by trying to restore the ratio, that That can be easily done with diet modification and other things, but at the end of the day, you still have too much, and that's also a problem. Now, this slide has a lot going on with it, and it may be a little bit hard to read, but again, the idea is that you have this injury, if you will. You have some inflammatory trigger that causes first inflammatory responses in the endothelium, dysfunction, if you will. So we get some kind of process that leads to the endothelium either being injured or thinking that they're injured, shall we say. I don't want to anthropomorphize endothelial cells. They don't really think, as far as we know, but they do behave as if they are injured, and that leads to inflammatory signaling. That inflammatory signaling can cause accumulation of, in particular, LDL and cholesterol. That inflammatory signaling will cause monocytes, which are a white blood cell, if you will, to get sticky. They actually roll along the interior surface of blood vessels. It's very cool to watch if you have a good video. And what happens is, as they roll, they'll hit a sticky spot, and they will activate and adhere. And then they will move out of the blood plasma and into what's called the intima of the vessel. And so with that oxidative signaling, inflammatory signaling, you do get smooth muscle cell proliferation, which causes enlargement of the smooth muscle layer, which means less stretchiness. Okay. Think about a bodybuilder trying to scratch their back. Have you ever seen those videos where they just can't get their arms around to scratch their back because their arms are just too built up? That's kind of what happens, only in the case of the vessels, when the smooth muscle cell wall thickens, they become less compliant. They can't stretch as much. They can't absorb that energy. Factor release, et cetera, et cetera. You're just progressing to a buildup of dysfunctional endothelium, a buildup of dysfunctional white blood cells, inflammatory signaling, which leads to almost an overt clotting situation. The point of this slide is just showing you that you don't even have to have complete occlusion. Like, for instance, you can see a complete myocardial infarction or full-on obstructive disorder, that sort of a thing. That's certainly going to be problematic. But 70% of the vascular events that are observed in clinic are actually pre-occlusive. That is, you have enough reduction in flow, you get a buildup of a thrombus there that can then break off and cause an embolus in other places, like particularly the lungs, or perhaps the brain, or in other parts of the body where you get basically an embolism that causes an ischemic disorder in wherever it's located. 70% of those are in that range. Only about 30% of the ones that progress so far to here. And that's why good interventions, prompt attention to patients that are pre-pathological, shall we say. This is why diet modification early on and slow change early on is more powerful than intervention later on. Now, this slide may be a little bit early, maybe a little bit out of place. I'm sorry if it feels like that, but it is an important concept that we need to deal with, because it's an ADE associated with vasodilator therapy. And it's called coronary steal, and that word means that coronary arteries are healthy and responsive to the drug therapy may actually exacerbate the ischemic disorder that's presenting. So let's talk a little bit about this. Let's say we have a blood vessel here and it forms a plaque. Don't worry about this side just yet. Maybe we have another vessel over here. As that plaque forms, this tissue down here will send signals that say, hey, I need more blood flow. We need more blood flow over here. So what will happen is that you will develop a collateral, and this is especially true. This is angiogenesis. You will develop a new blood vessel that will grow over and join here in order to further perfuse this tissue. This is particularly true in people who are, shall we say, biologically, if you will, biochemically female, because estrogen does promote angiogenesis. And so in biological females, we see much more collateral formation, and this is why they tend to be more asymptomatic when it comes to myocardial infarction. But in either case, so we've got this plaque here, we've got this collateral going on. And maybe you still have some symptoms, and so you see your physician, and they give you a vasodilator. Dipyridamole is an example of a vasodilator. And what can happen is that dipyridamole doesn't know whether an artery is diseased or not, shall we say. And if you have some relatively healthy arteries, they're going to dilate in response to that drug. And when you dilate, you reduce resistance. And so this normal area that is not diseased becomes even more perfused. You've reduced the resistance, and so you get even more blood flow to the normal area, which is basically stealing blood from the diseased area. So we're actually exacerbating the ischemia by giving a vasodilator. And that's why you have to kind of monitor symptoms when patients go on these types of therapies. And you guys can be a real help with that, especially if you're right there when that patient begins getting new treatment. This is called coronary steal, where the coronary arteries, the ones that are relatively healthy and responsive, dilate to the point where then they steal blood from areas that are already ischemic to begin with. And so we've hit our 30-minute mark. And so I'm going to stop the video here, let you get a break, let you reflect on what we talked about in the slides. And we will pick up next time, starting with chest pain and angina, often due to the occlusion and change in vessel hardness and so forth that we've been talking about this current lecture. So thank you for your time, and I will talk to you again in a few minutes.